Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr, I'm a GP, and today I'm joined by John Robinson, who is another GP who's been involved in the health informatics world for way longer than I have. I became involved in the sort of early 2010s. That's when I finished my GP training and became involved in medical informatics. But John's been involved since the 90s and before. So, John, thank you for joining us on the channel. Would you like to introduce yourself and tell us a little bit about your career?
Marcus, thank you very much for giving me the opportunity to be on your podcast.
Not at all.
Yes, well, I was a GP, and that was my main career all through my life. So I was working full time apart from a half day off until I retired pretty much. And so I know a lot of people have sort of taken time out and gone and done informatics jobs sort of full and things like that. But it was always a separate career for me and a smaller one because of the pressure of the practice. But yes, I qualified in 1977 and I went into practice in 1983. When I first did my house job in Exeter in 1978, we had a computer. Now, it wasn't doing anything clinical. It was really mostly admin. But that was the first the first, hospital medical computer system that I came across. One of the things I liked about it was the fact that it had what was on in the local cinema on it. And this was deliberately put on there to encourage people to turn the computer on and use it to get information.
Cool.
And I used that as an example of encouraging people to use digital things ever since then. Anyway, there weren't many computers around, but there was one in the hospital there. As a registrar, I saw a couple of practices demonstrating very early systems, but it wasn't mainstream at all. It was very much on the edge. And it wasn't until 1989 that we got a computer in the practice. And if you know your history, you'll know that was the time that we had free GP computers with the likes of VAMP and Meditel.
Yes, yes.
And that's really what computerized general practice. It was a scheme whereby we got the system supplied free, and they extracted our data suitably anonymized and all the rest of it, and sold it to drug companies so that they could see what was being prescribed.
Yeah, I remember. So Ewan Davis was one of the people who I think was involved in Meditel. Is that right? He was an old friend of mine. Sadly, passed away about 2 years ago this March, and he was the person who introduced me to really this world in its entirety. And I remember being quite surprised that it was essentially data pay, as in free computer and system, but the data is what pays for that, which is something we'd recognise now as potentially an anti-pattern or something we'd want to avoid because of the privacy implications. But right at the start of GP computing, that was the way it actually got started.
It was the way it got started. So there were two systems that were doing that, VAMP and Meditel, and there was another new kid on the block called EMIS. And we looked at EMIS and we thought it was very nice, but they wanted to charge us a great deal of money. So we didn't go with them. And in fact, we went with Meditel, which, as you correctly say, was Ewan Davis. And I think I hadn't really appreciated at the time that it was originally it was Ewan's father's company, which was putting televisions into practice waiting rooms and putting advertising health.
I see. Yeah,
one thing.
makes sense. The name Meditel.
Meditel came from. Anyway, Ewan took it over and moved into primary care computing, and so we got a Meditel computer in 1989, and we were very lucky. We got all the patients' names and addresses put on by whatever the three-letter acronym was that we were working for at the time. fact, it might have been more than 3 letters then, but I lose the will to live trying to think of all the different ones. And we used it for repeat prescribing, so we gradually got our repeat prescribing on it, and gradually started to add stuff to it.
Yeah. I think GPs of now might not quite have fully appreciated how much of a revolution the computer would have been in the world of repeat prescribing, because I guess in the late 80s there wouldn't have been as many people on repeat prescriptions, but the ones that were had to be handwritten on an FP10 pad every month and signed by a GP. And then the idea that you could transfer all that and have them printed so that you could then sign them
was phenomenal. I mean, yes, of course, most practices were working with Lloyd George envelopes. So the only technology with the Lloyd George envelopes was the treasury tag. We actually, in Wantage, and one of the reasons I liked the practice was we had what were known as the Wantage records. And it was the first practice with another practice in Wantage that had got A4 records in primary care. So coming into the practice, they were beautifully in order. And we then had a sheet at the front where we wrote down their repeat prescriptions. And we could see what they were. And we set up reasonable systems. But you're right, the ability to manage these things was very difficult indeed. And it was a complete revolution.
I'm reading a book at the moment called GP Computing by Lewis Ritchie, which I only found out about quite recently. And very interesting that the card size of a Lloyd George envelope was, I think, chosen just because it was the same size as existing stationery, I think for national service, possibly.
I think that one of the reasons it was chosen, actually, was that they fitted nicely into a First World War ammunition case.
Yes.
And after the First World War, there were a lot of empty ammunition cases. And we still had one in the practice that my senior partner, who'd been there almost as long as that, used to have his surgery, the records put in and sent down to him. In
an ammo case. Yes.
That's apocryphal as well, of course, but I rather like that, to think that up until about 2000, GPs were still using records designed to fit in a First World War ammunition case.
In the book, it mentions that there was also a kind of filing cabinet which had the right sized slots for these cards, which I think were to do with either national service or national insurance. And so the choice was made to stick with that size because it meant that these cabinets could be reused, which is kind of, it's expediency, but I think it's pragmatic. It's pragmatism as well, in that go with what you've already got, what works.
So the Lloyd George records were when he brought in insurance, and they were to record that you'd seen somebody, and there were 3 letters, I think, if I remember right. It was A, V, and C or something. That must have been appointment, visit, and I don't know whether C was a call. I don't suppose you got paid for a call, but anyway, there was, you just put a letter or something like that. You weren't expected to write any clinical notes. It was merely so that you could work out what to charge the insurance companies.
Fascinating history that this backs into, because we're talking about computers, but it goes right back to the First World War.
Yes, it does. The record keeping. It's a long way back. But the other thing about computers at that point was that memory was very tight and very expensive.
Right.
So our first practice computer had a server memory of 70 megabytes.
Wow.
That's just a decent sized Word document these days.
I mean, yeah, it's not an awful lot. It's not many web pages.
And so, the coding had to be incredibly tight and no loose sort of coding at all. Every single character mattered.
Yeah.
And of course, we had the read codes, and the read codes were introduced for 2 reasons, really. One is that 4-byte read codes, you could put in a clinical concept only using 4 bytes.
Yeah, very efficient.
Very efficient. And the other thing was that we couldn't type. GPs didn't type. They hadn't used keyboards. So putting in 4 characters for your clinical concept was much easier than trying to type.
Yeah.
And and also, geeks like me used to get to know them, so that you could just put them in very quickly. But it came about because of the circumstances at that stage, and it's interesting how subsequently things have developed, isn't it?
So just to give me a kind of window into what it was like using a computer in that era, when you made a clinical entry, would you have put any free text in there, or would you just have
Yeah.
put in the code of the thing that they saw you about?
No, you could free text. In fact, we dual kept records both on the computer and on the records for quite a number of years, before we had the confidence to go over, completely. But we were writing. We would take a code, and then with Meditel, there was a space afterwards in which you could put free text.
Okay.
So that really wasn't a problem. We didn't put very much free text, but you were able to do that. So you were able to have a record very similar to the record that you have now. Of course, they were green characters on a black screen. We didn't have windows.
Yeah.
They were all dumb terminals in the offices, and they were all driven by the server. And there was about one dot matrix printer. I don't think we printed prescriptions immediately. I can't remember. Maybe we did, but
Wow.
so they were fairly basic. But the thing is that I got slightly interested in audit, and kind of, how am I driving? Because we spend an awful lot of time seeing patients, and you record a lot of stuff in notes or one thing or another, and you don't really get a lot of feedback as
No.
to how you're doing. And then around that time, they established these things called MARGs, which were medical audit and something groups. I couldn't tell you what.
Research, medical
Well, it
audit
was
and research group.
double A. It was double A. So it may have been advisory, but and they started encouraging people to look at what was going on in their practices. And shortly before we had a computer, they offered to send some ladies down to the practice. And I think it was two who came and spent a week with us. And they did a 10% sample of the notes. We had 10,000 patients, so they did 1,000 patients, and told us how many had a blood pressure and how many had a weight recorded, and perhaps how many smoked as well.
Wow.
But they're, two people full time for a week and doing a 10%
Analysis. Yeah.
a 10% analysis of what was there. So we were interested in knowing that. And of course, once we started putting stuff into the computer, I thought, well, we ought to be able to see what we're doing. We've got a computer now. We ought to be able to see how we're getting on, what we can get out. And so that sparked my interest, really. And I thought, well, let's see what we can do with this reporting. And at that time, you could get a single number out on a sheet of paper if you wanted it in numeric format, or you could get a list of the patient's names and addresses.
Mm-hmm.
And on more than one occasion, I accidentally selected that, and I could have repapered the entire surgery with the amount of paper that came out of the but it was very limited, and and a bit frustrating if you really wanted to know what was going on.
Mm-hmm.
And I suppose I'd started to get interested, and there was a very good user group, and I went to the user groups, and the likes of Mike Bainbridge, of course, John Rogers. Did you know John Rogers?
I don't know if I know John Rogers.
Right,
I know Mike.
He was great, but a lot of those sort of people still around, and they were actually beginning to do things to the system themselves to make it do more. And I realized that you could actually see the code in Meditel. It's quite extraordinary now, but you could lift the bonnet and see what was going on. And I
Open
found,
source.
yeah, and it was written in Unix. And I found bits that had Mike Bainbridge's name at the top, or John Williams's name at the top, or somebody else's who'd just written a little bit of a ditty to do something.
Yeah.
And from that, I then thought, well, I can write a little bit of something to do what I want.
Excellent.
No, I'd never done any coding, but I sort of bought a dummies guide and taught myself some Unix and copied a lot of what they'd done. And one of the first things I did was to write a bit that allowed us to have a loop, which meant that instead of having one number on a sheet of paper, you could have as many numbers as you wanted, because it just used the same piece of paper and went round again instead of ending.
Yep.
And suddenly you were able to get a report about a number of things occurring on a single page.
That's very cool.
And that coincided with the 1991 new contract, which was the first time that they started asking us to measure things and record things. So then I think I must have started talking to Meditel, because we started using that to write reports for the 1991 contract that actually told you how many patients with hypertension you had and how many had a blood pressure and things like that. So, it was frustration of not being able to get what I wanted out.
Yeah, it's the classic story. I mean, anybody who has a personal need for something and then they find the tools, they work out how to use those tools. And in your case, you were lucky enough that you had essentially a sort of open source system. You could go and have a look, see what other people had done, and that inspired you to write extended queries.
I hadn't appreciated really until Ewan's funeral, which sadly is when one always learns an awful lot about people you've known for a long time, that he was very keen on open source and that the whole system had been designed with that in mind. And that was terrific, because it allowed a lot of people to develop a lot of features, which were, it was moved the system forward and was terrific. Of course, it's impossible for that to happen now.
It's not impossible. It doesn't happen because of the way that the software is procured. But we absolutely could have an open source GP system if we had the will to build one. There would need to be some kind of driving force behind it that would make it happen. In fact, that's how I met Ewan Davis. I met him at NHS Hack Day, and I was a GP. I'd heard about open source. I started talking to some people about, wouldn't it be great if there was an open source GP system? And I think in an effort to get rid of me, somebody said, why don't you go and talk to this guy? He can talk the hind legs off a donkey, and introduced me to Ewan Davis, who also wanted to do an open source GP system. Yeah. And on the same day, I met Rob Dyke, and I think the two of them, really, between the two of them, they changed the course of my life completely, because I started learning to code, got involved in NHS Ubuntu, and actually between myself and Ewan and Rob, the first project we started was Open GP SOC, and we were trying to come up with an open source GP system.
I remember.
And that idea is still not dead. I'm just working on it in a different way now.
But I think it would need more control, because I don't think you want complete amateurs like I was at the time fiddling with the code. And I do remember losing the passwords one day when I'd been in there looking at something, and the partners coming back for afternoon surgery, and absolutely no one could log on.
Oops.
So there were a few of those events, or I'd set off a report that took 72 hours and slowed the whole thing down, so it was impossible for anybody to
do any work. Ouch.
But in the early days, people didn't really mind.
It's super interesting to hear about this era, because although it's very basic computers, the fundamentals were there. This was how the foundations of GP computing got established. And it's also how we made so much progress in such a short time. Really, through the 90s, GP computing in the UK leapt ahead of every other country. We're still ahead of secondary care in the UK in terms of that ability to do audits, for example, the ability to code your own data. Clinicians in secondary care do not enter clinical codes directly into the system. So I'm not aware of any system where you're directly coding. So it's very different to general practice.
It is. You're absolutely right. And in terms of the audit, it was one of the things that struck me, that people would do an audit and say, well, aren't I doing well? 70% of my patients have had the right treatment. And I'll go back and do something else. And next year you say, oh, I've done terribly well. 75% have had the right treatment. But actually, if you've got the records and you've got it all in computer, you know who the patients are who haven't had the right treatment. So really, we ought to be concentrating on them. And I think that's something that is recognized now and takes place much more often. But I used to talk about audits where that's the one I want. I want to know who it is that I need to go and do something about.
Yeah, you want to be able to get the top level statistics about how well you're doing, but then equally go and then find the ones that are exceptions and go and fix those so that they are getting the right treatment.
It's completing the circle, isn't it? That's really important. And I guess that's something that has really interested me on through my life. After the early days, then Glyn Hayes came up with an idea of having some medical consultants for Meditel in about 1996. I think there were half a dozen of us. There was John Williams, Julian Costello, Robert Trahan Jones, Neil Davis, I think, was one. I was one, and I think there was another. There might have been one or two others. I can't remember. And we were taken on, for primary care input, for clinical input into the system, which was brilliant.
Yeah, it's amazing.
And Glyn said to me, "You're an expert in writing Visual Basic. Why don't you come and help us write the outputs for the new computer system 6000, as we had?" And so I said, "Yes, that would be great. Thank you very much." Now, I hadn't ever written any Visual Basic, and I didn't know anything about it. But I rather assumed that this was something you could make up as you went along. And I think it's true for an awful lot of us that we bluffed our way through most of our careers in that way, probably.
I think it's kind of true in that the thing you can't bluff is the clinical knowledge. And you have that's baked in. You've had to serve time, go to medical school, exams, postgraduate training, and experience. Layering that into software is relatively straightforward procedure. And you could do it in Visual Basic. You can do it in any language you like. It's just a case of learning the language. And for a certain kind of person, learning a language in a computer form is like, it's quite easy. And once you've learned one, you can learn another. It's also like learning Italian or Spanish. It's just expressing yourself, but in a different way to the language you're used to. And again, some people find that easier than others.
Yes, I think you're right. So I was very lucky. I was kept on for 4 years. I think the others only survived about a year. I don't know how. I think they smuggled me in under the radar. And eventually, in about 2000, somebody said, "Hang on a minute, who's this chap? What is he? I thought we got rid of all these people." And actually, by then, I felt I'd done as much as I could in that particular area. So I kind of put my hands up and said, "No, fine, thanks very much." And I was very lucky because a few months later, I was picked up by PRIMIS.
Okay.
And
so tell us a bit about PRIMIS then, because not everyone will know what PRIMIS is.
No. So at the end of the 90s, 98, 99, I should think, there was a national project called CHDGP, Collecting Health Data from General Practice. Have you come across it?
I've not heard of it, but the acronym sounds tortured enough to be realistic.
A big national project to see whether or not data sitting in GP clinical systems was of any value beyond those clinical systems. In other words, to the NHS for planning or this, that, and the other. And they actually concluded that there was good stuff there. And if it was going to be of value, it needed to be of high quality. Now, there's a novel idea.
Yes, data quality.
Coming round again, couldn't it?
It could do with it.
And so they put out a contract for a national service to improve the data and the quality of the data on primary care clinical systems. And there were a number of people who bid for it. I think they were largely the people who'd been involved in the project in the first place. And the University of Nottingham got it, led by Professor Mike Pringle and Sheila Teasdale, who you may also.
I know both names. I don't think I've met them.
Um, and they called their iteration PRIMIS. And so they got the national contract to do this. And the way it worked was we were what was known as a distributive network. And we had primary care facilitators in every, what were they in those days? They, district health authority, or I can't remember how far we'd got by 2000, or whether we got to PCGs or PCTs, or, but locally there was a PRIMIS facilitator. We then had the team who managed a group of facilitators, regional consultants, learning consultants, they were called. And then we had a core centre of people who did things.
Right.
And to start with, I was invited to be on an advisory board. And then I was taken on as a full clinical advisor. But what happened was that we would decide that we would look at a particular clinical topic, say epilepsy. And the advisory board, which consisted of about 20 people, a lot of, really quite interesting people. Jeremy Rogers was on it, and a public health chap from NHS England, or whatever they were then, Public Health England, I suppose. And all sorts of different people. And we would say, well, what do you think should be being looked at? What would you expect to happen to a patient with epilepsy? And so, in effect, you'd kind of design an audit, or collecting the information you thought was of value. And this was sent out to practices, and they then ran it on their thing, and a floppy disk was sent back to PRIMIS. PRIMIS analysed it centrally and sent them back a summary. So it was providing an audit service.
I see.
And It was encouraging the practices to use the proper codes to record the diagnosis and things like that.
So like all these things, there's an incentive for everybody in the process, as in the GPs were incentivized to use high data quality because they would get back a report about their own activity from PRIMIS.
Exactly.
And the knock-on effect was that meant that nationally you could get those returns and aggregate them, and you've got good quality data nationally.
Yeah, exactly. So that was what was going on. John Williams was a part of PRIMIS as well. And he approached me one day and said, well, I know what you've been doing. And if you put that together with what I've been doing, don't you think we could write something better than what they're using at the moment? And so we set forth and we wrote a bit of software which became known as Chart.
Right.
Which was a tool to import data from the clinical systems and then display it in meaningful, sensible ways, like tables and graphs and drill downs,
Great stuff,
and all sorts of things like that. And we gradually developed that, and we showed it to PRIMIS and said, "Would you be interested?" And they bit our arm off for it, and so we started using it there, and it was used, I think, probably for about 15 years for a lot of different topics and projects of one sort or another. And what we'd actually managed to do along the way was we wrote in effect, a programming language within it, which allowed you to manipulate the columns of data in all sorts of fancy ways.
Very good.
And having done it, sort of years later, the guys writing the reports at that stage would do these most extraordinary things. How on earth did you do that? Oh, well, I put this one together with this one or that one, and you think, oh, it had a life of its own. It would do things that you had no idea.
It's really marvelous to see that period of time had that cross fertilization ability where a GP could come up with a query of their own and have that used more widely and combine others to make the queries they want and that sort of thing. And it kind of makes me a little sad that we've lost some of that creativity around our systems, because the systems have become very ossified and they're commercial products now. They're worth a lot of money. No one is going to let clinicians anywhere near them anymore. And that's what means we're sort of frozen out of the loop of innovation now.
Yes, I mean, we dealt with the data that came out of the system reports. We didn't get it any other way. And so we weren't reliant on the systems or in altering the system. But it worked very well. And we worked along with some commercial companies, pharma companies and things, who wanted to put something back and wanted to do some audits or something. I mean, there's no such thing as a free lunch. You knew that if they made an anticoagulant, they'd be keen to sponsor a tool that advised giving more anticoagulants. But if it was good medicine, and it didn't specifically advise one over another, then we felt that was a reasonable approach.
Yeah, that's it. You would call that sort of co-terminosity rather than a conflict of interest. It's just that, giving good care should be a priority for everybody. What you don't want to be doing is unwittingly being a stooge of a commercial agenda that's skewing the prescribing towards a particular brand, for example.
And it worked,
and you weren't.
And it worked very well. And we maintained our reputation of providing high quality stuff. And I think the companies got credit for having provided a high quality tool. Grasp AF was a tool. I don't know if you ever came across that, but
I've come across it. Yeah.
That was one that was written that we did that. But I mean, coming back to PRIMIS and what happened with PRIMIS, we were quite a large organisation. I think probably 60 people or something like that overall, and we had the big national contract. And as all these sort of things, it came to an end. They decided they weren't going to give us a nice big contract and then keep us fully occupied and tell us what to do. We then had to move from being fully funded by that to become a business unit of the university. So we had to earn enough to wash our face. And that's an interesting time. When you're fully employed by a public service, there's a tendency to strive for perfection and not for economy. The emphasis on it can be getting things absolutely perfect. It doesn't matter how long it takes, because nobody's actually counting how long it takes. So when you move to a commercial style organisation, there can be quite.
It does matter, yeah.
It matters. It can be very different, and it was very interesting to see that sort of turn. And that was, I can't remember how long ago. That was maybe 2013, something like that. But we were very successful at it. And we're still here now.
Yeah, it's amazing how some of these organisations have got real longevity. Actually, despite living in an environment in which we've had so much churn. And you mentioned primary care groups, primary care trusts. We've had CCGs, ICBs, strategic health authorities, and it's bewildering even for people who are involved in it, I think. And the latest round of churn is basically to sack 50% of people from the ICBs and get rid of NHS England. And that's caused utter chaos. And a number of big organisations have essentially lost their funding through that as well. I mean, I'm concerned for the future of PRSB, because they've been cut off at the knees by the fact that they're not getting any NHS England funding.
I sort of compare that situation that they're in at the moment to the situation that we were in. I think the environment was more favourable to us at the time that it happened to us than it is to them. I think now it is challenging. It's challenging getting money from anybody, and with nobody's got any certainty as what's going forward. So it does make it difficult. But we've kind of moved over time. We still have national contracts and provide all the coding for the vaccination recalls. And actually, it's not so much the recall as they want to know who has had the vaccinations. So it's the report on it. And we do those things. And we also maintain something like 250 ref sets for NHS England. So there are a few sort of big national contracts that we hold.
I think ref sets are something that we'll probably cover in a future episode, because I think there's a lot that would be of interest there. And we talked before the recording started about the need for these educational resources to be out there. So I'd love to do some more episodes, and I'd love to have you back and talk about ref sets. What are they? A bit more about terminologies. And I think, there's a few people who we definitely need to draw into that discussion.
I'll try and find out before the second episode then.
So, but very briefly, just to cover off what a ref set is, it's essentially a kind of curated list of codes in a particular coding terminology.
It's a subset, in effect, with a particular purpose. Now, we tend to think when we talk about a ref set or a code group or a value set, because they're really all much the same expression, as trying to define a clinical concept. So that is certainly one type. So let's say, we wanted everybody who had ischemic heart disease, we would look for all the codes that could represent ischemic heart disease, or asthma, or diabetes, or whatever it is. And that's probably what most people think of when they think of a code group or a ref set. And that's certainly true. There are different types of ref sets. So you can have ref sets that limit the codes that you can put in to a system. So, you could have a list of codes for acute renal injury or something if you're a renal person. Or there are some that are very, there's one that contains most of SNOMED, but not all of it. And you think, that's a bit odd. Why have a subset? But there are other reasons. So there can be to limit the entry, or it can be for extracting data. But it's to constrain what you're looking for.
Absolutely. So it could be used in actually the design of the system. It could be used in data extraction. It could be used in research. I know that they were used, for example, like the COVID shielding query to know, so that they could determine who should be advised to shield. It's a very wide ref set that's applied and said anyone with any of these codes should be given the reminder of the option to shield, that sort of thing. So I think we probably should do a deep dive into ref sets. There's one of the things that you've also pointed out is that the educational materials out there for things like ref sets are very poor. And the ref sets are often curated inside an organization. And so from the outside, if you're like me and, not working for any of these organizations, you can't see them. A lot of the time they're hidden from you. And that means it's very difficult to learn.
But there is a movement, quite a strong movement, to share ref sets. And you can find quite a lot of ref sets that you can download. And for a presentation recently, I downloaded 10 different ref sets for asthma off the internet. And they used something like, I think it was 700 codes between them, but they used a huge number of codes between them all. If you looked at all the codes used in all of those 10 ref sets, there was a large number, very large number. If you looked at the codes that were used by every ref set in that group, it was 35.
Right. So the overlap.
So the overlap's tiny. And there's no description that makes sense as to why one is one and one is another.
Yeah.
If you look at the metadata, they don't really tell you anything. So I think this is a real problem about understanding, what do? You go and get it from these people, you go and get it from them. They're nice people, I go and get it from them. Do they know anything about it? I don't know. What was it designed for? And I think that's something that's missing on a lot of people's understandings.
Absolutely agree. And in some ways, the tooling that we use is that's the place that you could enforce some of that usage and misusage data to be stored as part of the metadata, so that you know what a ref set is designed to do and what it's explicitly not designed to do, and have some of that baked into the usage of it. But there's no standardization around how you would record that and where you would record it.
And there are one or two big organizations who are pushing fairly strongly on this, and they have some very good ideas, but I'm not sure that they're necessarily right or the best ones, and we might find ourselves being pushed into that. And I think, that's something we need to guard against and try and influence. And actually, if we can define what the best solution is, then we can start to influence people. But yeah,
Yeah.
no, I think it's an important topic, and one that
Uh,
deserves more, not only more time perhaps from here, but it deserves more investigation and research, really, in understanding.
and
Um,
for me, crucially, I think we need to have an open standard on these things. So whatever standard it is, it can't be tied into some commercial technology, proprietary platform, or even an organization, because you know me, I don't trust any organization to still exist in 5 years, 10 years, 15 years. We have to have these standards outside of the organizations. And
well, exactly. Yes. No, I think you're right.
I've been working, I've been thinking about this quite a lot actually recently, because for the past sort of 3 to 6 months, I've been mulling over the idea of an open clinical terminology. Um, so, and I know to a lot of people that sounds like utter madness, because essentially it's replacing SNOMED with something that's open. But as part of that work, you need a way of serializing a ref set and making it shareable, adaptable, adoptable, tweakable, but still maintaining some kind of inheritance path, some hierarchy or some provenancing, so you know who authored this ref set, why they did it, what it's for. And there are some technologies that have already got this very well done. So if you look at an OpenEHR archetype, for example, in the Clinical Knowledge Manager, there's an entire page of metadata at the start that tells you what it's meant to be used for and what it's explicitly not meant to be used for. And that can help you to choose which archetype you should use.
Yes, what they don't do in terms, of the ref sets who do that, they may say what exactly it is meant to be used for. They don't tell you how they made it, and and their understanding of that process. But we're probably getting too detailed in ref sets, or we'll have done the next episode before we've done the first.
Well, this can be a little teaser for that episode. If you want to know more about terminology and ref sets, in a few months we'll do another one that goes into more detail. So that's, we've talked about your original part of your career, how you got involved in Meditel, PRIMIS, and you're currently, or until recently, you were NHS Digital and NHS England clinical lead. The one thing we haven't talked about is your chairship of the primary healthcare specialist group, which you were until quite recently, and you handed over recently to Ian Thompson. So tell us about the primary healthcare specialist group.
Primary healthcare specialist group, indeed. I mean, last year we had our 44th annual conference.
Wow.
And I don't think there are many informatics groups that can claim to have had its 44th annual conference.
No.
And it was actually founded in the late 70s by John Perry, who was I think he'd probably describe it as a public health consultant in Oxford, and invented the OXMIS codes, which were used in Oxford. But he was very interested in primary care computing, and he did get together a first conference in Oxford and somebody will tell me I'm wrong, but I think about 1978.
Wow.
And people came from all over the world to show off what they were doing. So it
Wow.
was an extraordinary start. So they weren't held annually at that point until the 80s. Now, when I started, I started by going to a user group, Meditel user group. And at that point, I realized that the people who were really keen and interested also belonged to this other group called the Primary Healthcare Specialist Group. And in the early days, they held 2 conferences a year. And you'll probably remember, I mean, digital conferences, everybody wanted to go to. It was the big buzz, wasn't it?
Yeah.
And we had a summer conference, and there were often 200 people at it. And that generated a lot of income for the group. And then they had their more academic conference in the autumn, which was a much smaller group of people who were really interested in informatics as opposed to all things digital. And that, well, like all these things, everybody sort of stopped going to those conferences, and that dropped off. So it joined up with the BCS right at the beginning, but we had a fairly loose affiliation with them, BCS, British Computer Society. And the group had its own administrator and ran its own finances, its own conferences. And in fact, it also ran the Journal of Primary Healthcare Informatics. So it started that journal and ran it for some years. But I can't remember quite the point, but there was a point in which a lot of people ran into trouble with paper journals.
Yeah.
And like everybody else, we got into debt with trying to publish the journal. And so BCS slapped us on the wrists, very kindly paid off our debt, and took us more under their wing. So we became a proper specialist group and not
Of the
allowed
BCS, yeah.
to run our own finances and things. So that was sort of kind of the history of it coming up. But the autumn conferences were always absolutely fascinating.
Absolutely.
And you've attended many as
I've
as
been
well.
to lots of them. I was at the last one, the most recent one, in I think November last year,
Yeah, yeah,
and that was fascinating and really great to see the room full of a whole range of people, including people who were around at the very start, people who've been around for the entire 44-year history, and then new people joining all the time, and a nice diverse and range of people in the room, so that hopefully that knowledge being passed down to a new generation or even generation below.
very much what we want to do. And as chair, I reintroduced the 2-day conference because the academic one used to be 1 day. But we started it on the previous afternoon by having an AGM in the room where we had the conference the next day. So we were actually paying for that room for that day anyway.
Yeah.
And I thought, well, why don't we fill it up? So I said to BCS, you have a mantra, making IT good for society. I have a mantra, making IT good for primary care, which is, supports your mantra. Now, I want to put on a free education day on the first day. Will you support us? And they did, and they've continued to support us to do that.
Yeah.
And so the first day is designed as an education day, and it's open free for anyone. So the idea is that anyone who's interested in it, from practices or whatever interest you have in primary care,
Can just come along. Yeah.
You can come along, and hopefully you then think, oh, this is quite interesting. Maybe I'll get involved. And so I think that was
Fantastic.
one way of trying to widen things. And then we also have some prizes. We have the John Perry Prize, which was founded in memory of John Perry.
Absolutely, yeah.
And and that was for excellence in primary care. And we've had a lot of very worthy winners over the years. And more recently, we introduced the Early Career Prize, which is now held annually in memory of Hildy Frank, who you probably remember.
Yes,
as well.
I remember Hildy.
And that's for people in their early career, and it gives them a chance to present their research. We don't give them a great deal of money, but I think it's important that they have an opportunity to stand up and present it to a group of informaticians, and that's worked very well. And then more recently, we introduced the Travel Awards.
Yes, the Julian Costello Travel Bursary.
Now named after Julian Costello.
Yeah.
That's quite right. And I tend to organise those, and that has been a great thing, really, I think, because it encourages people who are starting off in their primary care informatics career, who have an interest in it, to get the opportunity to go to the European meeting.
Yes.
And as you well know, there is no big informatics conference, scientific informatics conference in this country. And when you go to the European conference, you find there's all sorts of people in England doing all sorts of interesting research and presenting it in Europe. And that's where you go to hear what's going on in this country, because we don't have a scientific conference at present.
Wow.
But it also, opens it up, because there are often world leaders there, and there are incredible variety of subjects. And so it's been great. I mean, I've been to them for some time, and tend to try and go, as do a number of us, and so that gives us the opportunity to look after those awardees that come, and to introduce them to some of the people that we know, and we know a few people nowadays.
Excellent. And I think all those prizes and the bursary, they are an important leg up, I think, for a career path which is often a bit disorganized, in that there is no direct path to a career in informatics. There's no training post. It's very difficult to find your way into it, except by accident and by a little bit of bouncing around like a pinball until you settle into something, find an organization that can help you. So definitely my advice to anyone who's starting out in any kind of informatics, whether it's secondary care or primary care actually, is join the primary healthcare specialist group of the BCS, because even if you are not a primary care person, you're not a GP, and you don't see that as your focus, there's a lot of stuff you can learn from that history, the stuff that we've been talking about, some of the things that have been absolutely nailed for years in primary care that secondary care still can't do. I mean, secondary care systems still can't really reliably produce any concept of a repeat prescription. I mean, isn't that amazing in 2026?
Yes.
That a feature that was essentially the birthplace of primary care informatics, repeat prescribing, is still not implemented in clinic systems that they use in secondary care.
A very common theme through my informatics career is, this is something we asked for 10 years ago.
Yeah.
Or this is something we asked for 20 years ago. And now this is something we asked for 30 years ago.
Yeah. I think when we see that kind of intransigence, my response is always, we as clinicians need to take over the asylum, as it were. We have to reinstantiate that kind of exciting, innovative environment you had in the 90s. Once again, that can happen because we've been stifled by the systems. I've used secondary care systems. I had a 10-year hospital career, and then I've used primary care systems, and really neither of them are fantastic now. Really, if you have an idea in the NHS, it's very unlikely that you'll be able to get that adopted into a system that you currently use. More likely is that if you did find some advice from somebody in the NHS, they'll say, go and become an NHS clinical entrepreneur and take your one little idea, turn it into a business and try and sell it to the NHS. And I think that's madness, because firstly, a lot of the clinicians that we're talking about don't want to set up a business. They just want their innovation to be available to them and others in the system they're using. And they'd quite happily donate it for free to the NHS. Also, the NHS is an incredibly difficult environment in which to run a business and sell into. And we've alluded to the difficulty of supporting organisations, and things like PRIMIS and Primary Healthcare Specialist Group have both had problems maintaining themselves. Why would you suggest to a clinician who's not got business experience that they should be an entrepreneur? I would close that entire department down tomorrow and say the funding goes towards talent spotting good ideas across the NHS and making them happen within the NHS and for free. Because that's the only way we'll get the benefits.
I guess that their systems are so big that it's very difficult for them to customize them locally and maintain that. And it becomes increasingly difficult to get that flexibility, doesn't it, with bigger systems? I
would say that's true, but there are lots of things that we've been asking for decades that we still haven't got, that everybody needs. So QRisk 3 would be the absolute classic example of this. QRisk 3 still not implemented in GP systems, even I think it's 12 or 13 years since it was released. And QRisk 2 has been officially deprecated, and there are official notices, and there are all kinds of strategies, reports and memos floating around the system, but no bugger is actually writing the code to fix it, and no one seems to know how to unblock this scenario. It seems to be
yes, and I think that kind of moves nicely into discussing algorithms.
yeah. It's always fun to talk about clinical calculators and algorithms, because that's my thing.
Because I think I think the system suppliers got frightened off because of the episodes where they weren't giving exactly the correct answer.
Absolutely. Yeah.
And
A couple of
it's very
examples of
difficult.
that.
So, they're all dependent upon a selection of variables. Each of those variables is a clinical concept.
Yeah.
Each of those clinical concepts is defined by a code group
Yeah. A
that
ref
we've
set.
already said is, is defined in all sorts of different ways, with different accuracy and one thing and another. But they will be published. So when the algorithm is published, the code group is published. I guess the answer is that code group then, if you stick to that, will give you the same answers in the predictions, as the research did.
That's
But
right.
if you've missed out one of the main codes for diabetes in your research, do you not
Yeah.
look for that in your practice, because you're going to miss the pay, or when the codes change and things like that. But yes, they didn't implement it as it should have been somewhere along the line, and I think they've got their fingers burnt, and people are anxious about that.
Yeah.
But it is very difficult because everybody is now developing their own algorithms. Often they're very complicated. And one of the things we do in PRIMIS now is we work a lot with research groups. And we try and get in early with them and help them develop their code sets as they're doing their research for the first time. And therefore, hopefully, they get high quality code groups.
Yeah.
Because we have had situations where we dealt with people who've done their sort of primary research and say, right, now we want to try it in real life. And you look at their code groups and think, I'm not sure about this.
Absolutely. Yeah. So they need to be factoring those code groups into the original research.
We
And
try and help them get it into the originals.
I would go a step further and say they really need to be designing their algorithm and the ref sets that go with them with the intention that these will be implemented in software after the research is published. And
Right. So,
they often partly do that, but they really need to think about publishing the reference implementation of the algorithm at the same time as they publish the research itself.
I think the biggest problem is implementation. And I'm sure you've seen the graph too, with a great big water pipe of all the algorithms, and comes out with a drip of water at a tiny pipe at the other end. The number of algorithms that actually get through to be used is microscopic compared to the amount. And they're not bad, the research is all good, but nothing gets through. And that's the implementation. And that, I think, is the biggest problem. And one of the things that we often do with research groups is to implement it into practices for them to test on real data in a number of practices.
Yeah.
And that means putting it in using the clinical reporting functionality, which is better in some systems than others. But what you can't do is you can't do it on the fly in a template, because they won't accept complex algorithms. That maths isn't available to you, and probably the computing power to do them isn't either. And so they don't get a chance to test these in a way that proves they work and to get them fully implemented. So
I think that does highlight a deficiency of the systems we're using, because if they're not doing the things that we need from them, then they're unfit for purpose. And I think gradually the GP systems that we've had for decades have sort of stayed still, and they haven't moved with the times to enable us to do these kind of things. But my solution to the implementation problem of clinical calculators and algorithms is open source them all. Not because of any ideological open source thing, although as people will know, I'm ideologically tilted strongly towards open source. It's more just the sheer logistics of it. If you have 50 clinical systems and you want them all to have the same clinical calculator in there, that means 50 implementations in closed source. And that's going to be at least 50 times the cost. Whereas if you have one implementation, which we all put our testing resources into and make sure it's right, then that's just 1 times the cost and everybody can use it. And so to me, that is a solution in its entirety. If we're not going towards open source for these solutions, we're missing a trick, surely.
So you're really talking about APIs here, are you? Where
It doesn't have to be behind an API. I mean, you can open source it in a language, and then that can be used even from a different language. You can often call, for example, into C from Python, for example. So there are ways of doing this.
Yeah, there are ways of doing the mathematics.
Yeah.
Absolutely. What you have to do is then extract the variables out of the record still.
Yes.
And you're still dependent on code groups.
Oh, you can't do it without code groups, and they should be open as well.
Well, they can be open, but they still got to be implemented in the system. But yes, I think there's work that needs to be done there. But as we see a lot of very good research simply not getting out,
Yeah.
Because we can't do it with our systems, we need to do something.
We've got to do something differently. I think, having worked within this system, working with system suppliers trying to implement things, we have to pursue a policy of excuse minimization, because the excuse that's given by a clinical system is these are medical devices and we don't want to go there, or they're complicated and the software is worrying us, or we're worried about getting the wrong ref set. And we can solve each of those for them completely by firstly open sourcing the algorithm and having an external algorithm which they're encouraged to use, which we test and we say this is right. So now that the system supplier doesn't have to worry about whether it's right or not, it's not their code, they are trusting an external body like PRIMIS, a trusted outside body. In the case of growth charts that we've done with the Royal College of Paediatrics, they're trusting the Royal College of Paediatrics. And if you can't trust them on growth, who can you trust? So we publish the algorithm, we publish the ref sets, then the stage further, which you did mention, is you put it behind an API, which makes it even easier for them to, as a system supplier, they have outsourced the clinical risk that goes with that. And we have minimized to zero all their excuses, because now all they have to do is select the right clinical codes with your ref sets, call the API with the data, and store the result. And we've taken away all the complexity. They have no excuses left. That's the way we have to approach this. And it's got to be one by one. We do QRisk 3, then we go and do CHADS 2 VASC and whatever comes after it. And we just keep working until all the algorithms that clinicians need have been converted.
Yeah, I think there's certainly ways to do it. I think the problem is getting people to engage with it, isn't it?
Definitely.
There isn't an application within the clinical systems that allows you to call an API. They would have to create one. And they would, they're going to create one that allows you to put research ones in, or they're only going to create ones that have already accepted and everybody knows they're going to use, and these sort of things. And they are very stretched for money and time. And we struggle, don't we?
Well, yes. I mean, I think the system suppliers have got it good, to be honest. I mean, stretch for money and time is their own internal problem. They're commercial entities, but they do have a rock solid contract with, essentially a duopoly. They're business wise, they can guarantee that they're going to be splitting 500 million quid over 5 years between the two systems in England. So if they can't run a business on that kind of guaranteed income, then it's mismanagement. The market will eventually displace suppliers that don't provide the things that we need. Isn't that capitalism? That's the way capitalism works, isn't it?
I think we may be at an interesting time where we're beginning to see the beginning of that.
Hopefully so, yeah. Well, that's been a really interesting tour around some your career and some really interesting concepts. We've covered your time in Medital, PRIMIS, Primary Healthcare Specialist Group, some really interesting debate there as well. And I'd love to have you back, and we could go into more detail about ref sets. What are they? How do you author a ref set? Where should you put this ref set when you've authored it? How does it get implemented in software? All of these questions I have. And I think, we're trying to develop that primary care or general clinical informatics educational resource that I think we desperately need. So I'd love to have you back on.
You're very kind.
But for today, thank you very much for your time and for being on the channel.
It's been a pleasure, Marcus.